Okay, we're talking about arterial ulcers. You can see a picture of those there. They're usually medial and lateral metatarsal heads and the tips of the toes. So you can see they have they're round, they have a regular shape. So it looks like they just took something and cut a hole in the foot. So it has a round, consistent shape around the edges, as you can see in that picture. And you can tell it's really, really red, so it's painful. And remember, these are the patients that we know are going to have some pain. At first, they're going to have pain that's with exercise, but then they're going to have pain at rest. And as you can tell, like I said, that foot looks very painful as it is. So then we're going to look at management. So we talked about before signs and symptoms: numbness, burning, pain, primarily when their feet were in bed. They like their feet down. The pain's reproducible. We know they're going to walk so far and then we're going to be able to reproduce that pain. We may hear a bruit over the femoral or the aortic arteries. So now we want to talk about management. They do have poor healing, so we want them to keep their feet dry, clean and dry, free from pressure or irritation. Debridement is only performed if they know that reasonable blood flow is established. Otherwise, we know it won't heal. So you've heard me talk about before, we have to actually look at those vessels and see how those vessels are working to see if there's actually blood flow established there. Because if blood flow's not there, we really don't want to start amputating or doing any of those kinds of things. So we want to evaluate where the flow is. And we do that with different diagnostics. We can do an arteriograph where we actually go in and inject dye and visualize arterial blood flow. We can also do segmental systolic blood pressure measurements where we take a blood pressure cuff and we take a blood pressure at the ankle, take a blood pressure on the calf, take a blood pressure on the thigh. And those segmental blood pressures are one way we can actually tell how much blood flow is in that area. And it's one of the ways that we can actually help with prevention of some of these problems too. And another thing I want you to remember is the ankle brachial index. You measure the blood pressure at the ankle and at the arm while at rest. And it's the ankle systolic divided by the brachial pressure. So the brachial is going to be in the arm in the supine position. Normal ratio is greater than 1. So that's one of the measurements that we can actually use. Like I said, if we're trying to help patients before they actually get this far, we can actually do some of these measurements as a pre to this problem. An ankle brachial index is figured if it's less than 1, the patient has PAD, but with a patient with diabetes, this test can be falsely positive because we know that patients with diabetes have blood flow issues and it's not necessarily an arterial problem. So that's one thing that we want to look at. Another couple of things we'll look at is the exercise tolerance test. So we'll put them on the treadmill until they have symptoms or 5 minutes. So again, we're looking for that intermittent claudication. We said it was reproducible. We can put them on the treadmill. We can have them exercise and we can see if the pain comes back. Usually there is an increase in the pressure waveforms when someone walks, but with PAD, the waveforms are decreased. So you see the waveforms on this picture. So if they had peripheral arterial disease, they wouldn't be as peaked. And then plethysmography is blood pressure cuffs attached to both upper and lower extremities. And again, we do some graphing of these pressures, and those tell us how well the blood pressure or the arterial pressure is in the different extremities. And we do those sorts of things before we decide about amputation, because we want to make sure that there's adequate blood flow before we go in and start taking off parts of the limb. Otherwise, it's not going to heal as effectively, and they're going to have problems anyways. So, what do we have them do? Well, we want to reduce their risk. So, provide teaching, so foot care teaching, smoking cessation teaching, lipid control teaching, hypertension control teaching, control those comorbid conditions. So, we talked about some things that put them at risk. So, diabetes, hypertension, obesity, sedentary lifestyle, age, cardiovascular disease, control some of those things that we can control. Exercise, encourage them to exercise 30 to 45 minutes supervised with claudication. It must be client specific, so you really have to monitor the patient when they're doing exercise if they have claudication problems. And then with the gradual increase, what we'll find is they potentially will be able to walk further and further without any clear pain. Prevent injuries. Can't say it enough. Good skin care. All of those things that were pointed out on the slide before, keeping the feet clean and dry, checking them every day, doing most moisturizers except not between the toes, making sure the shoes fit, make sure they're not wearing sandals, making sure they have white cotton socks on. Elastic or support hose should be avoided. Medications. What kind of meds can we give them? Well, the meds that we consider are Trental, Plavix, aspirin. Those help decrease the stickiness of the platelets, and they allow circulation. They allow more of that blood flow through those areas. Because remember, when you have plaque from smoking or from lipids, it can cause jagular edges, which can cause platelets to stick together, which can cause clots and strokes and all of those DVTs, all those kinds of things. Positioning, we want them to avoid crossing their legs. We want them to avoid standing for long periods of time. They should seek a comfortable position and report any edema. No restrictive garments. We don't want them to wear garters. We don't want them to wear elastic, real tight elastic socks. They can wear TED hose or support hose. Some of those have to be measured so they exactly fit the leg. They need to talk to the doctor about that before they actually start doing that. Don't elevate the legs above the heart. Again, if they're a real edematous, it can cause even greater issues, so we don't want to do that. You want a warm environment. That helps with circulation. You want them to wear insulated socks. Again, that's going to create heat in the legs. That's going to help with circulation. Don't apply direct heat because they don't have a lot of sensation. Avoid stress, caffeine, and nicotine. All of those things cause the vessels to vasoconstrict, which is going to be a problem for these patients. Percutaneous transluminal coronary angioplasty, that's just like a cardiac cath. The difference is what we're doing is we're going to go in and we're going to look at the arteries in the legs. We're going to look at the aortic, and then as it branches off and it branches down into those legs, we're going to look at how those arteries look. Usually we go in through the femoral artery, and we'll look at the, sometimes we'll have to do what we call a fem popliteal bypass, and that's where we actually put in either saphenous, we could use the saphenous vein, to bypass an area that's constricted or totally occluded, or we could use some grafting material that could bypass that area too. Of course, the patient's best prognosis is going to be with the use of their own vein, but we could use synthetic. Pre-op, it's going to be just like it would be if we sent them to a cardiac cath. We're going to do baseline vital signs, peripheral pulses. We're going to mark with ink the pulses on their feet, on their ankles, report if they have increased blood pressure, report if there's any signs of infection, and then post-operatively, we're going to put them in bed rest, lie them flat, monitor the site, wrap a light dressing if needed. They might even have a vascular boot on. If we do a femoral bypass, we're first consider the limb ischemia, so we're going to monitor those pulses, make sure that we have blood flow in both legs. Clots of the grafts is a major complication, so you heard me talk about it. If we have a cool, painful, pale, pulseless extremity, then we've got ischemic blood flow, so there's no blood flow. We'll use anticoagulants like antiplatelets, which we plate Plavix, aspirin, those kinds of things. Complications are infection, bleeding, and compartment syndrome. And remember, compartment syndrome's when you get pressure between the fascia when there normally is no pressure between there. We can do a balloon, we can do a stent, we can do an arthrectomy. An arthrectomy is where we actually go in the artery and we'll pull out a clot. We can do all of those things. Then we can do a fem pop bypass if needed. So arterial bypass and reconstruction, that's what I was talking about when I talked about a fem bypass. It begins, we start with a arterial graft, we make road maps around the obstruction, we make sure their inflow is adequate before correcting the outflow. So remember we talked about inflow and outflow in the beginning of this chapter. Femoral artery bypass, connect to posterior anterior tibial to the perineal artery. Most successful is, like I said, the patient's own saphenous vein. Can use synthetic, but own is better. Valves are disabled on the vein, so it becomes an artery. So they kind of turn it upside down so the valves don't work correctly, and they use it as an artery. The considerations are based on previous revascularization and at what level they did the revascularization. It does not raise the level of amputation. Mortality rates for amputations are at least as high as arterial bypasses, and there's no difference in loss between an amputation and a successful bypass. So they're going to look at all of those considerations before they decide what they're going to do. Revascularization is the first option if it's possible. So perioperative care, I told you a high incidence of infections was possible, so give antibiotics before the graft. Always compare with the good leg, obtain vitals, mark the pulses, like I said, bed rest after surgery, keep the affected limb straight and avoid bending, and always check that dressing. You've heard me talk about that before. What happens when that dressing starts to bleed? You're supposed to be checking it every 15, then every 30 times 2, then every hour times 4, and then every 4 times 24. If that dressing looks different than it did at the beginning, there's a concern. You're looking for hematoma. If it starts to gush, you're going to place pressure. Complications, bleeding at the incision. Infections more common with the synthetic graft. You've heard me say that over and over. Anytime we place something that's not the same as the body, it's got a potential for something to start an infection. If it becomes infected, the patient usually will have to have an amputation after that, or graft occlusion. Sometimes there will be a jagged edge along where they have actually sewed it together, and so then it starts to form an occlusion with a clot. Self-care after this, increase in activity. They need to do regular exercise, climb stairs, going out of doors. They need to get moving. Leg swelling can last up to 2 to 3 months. They might encourage them to wear elastic wraps when ambulating, but they don't want them continuously and they don't want them too tight. And definitely smoking cessation. A lot of times vascular physicians don't even want to consider surgery unless the patient is going to quit smoking. So it is a big deal if they're smoking and they're doing these particular problems. So acute arterial occlusion, etiology and pathology, 90% of these occur in the lower extremities. Acute occlusions are caused by major issues in the collateral vessels haven't really formed. So they can form when it's a slower onset, but in this particular case, it could be caused from trauma, embolisms that lead to distant areas of necrosis. It could be a thrombosis from atrial fib, from an MI, or from a prosthetic valve. Manifestation, look at the 6 Ps, and the 6 Ps are listed there. Pain, pulselessness, poikilothermia, which is warmth versus cold, pallor, mottled cyanotic paresthesias, loss of position sense, difficulty detecting pressure, happens in advanced stages. Paralysis, there's advanced stages. Once this sets in, stiffness is irreversible, amputation has to happen. Muscle necrosis starts in 2 to 3 hours after occlusion. So if there's an occlusion in the artery, we're going to see that necrosis of the muscle 2 to 3 hours after. So anticoagulation therapy needs to be started as soon as possible. We need to initiate treatment promptly to prevent permanent damage or loss of that extremity. So if we have to do a surgical embolectomy, a couple of things we're going to look at as pre-op considerations. Their physical condition, so their age, their ability to take care of themselves, comprehension level, willingness to participate in rehab, and condition of pre-existing illnesses. Goal is to attain independence with prosthesis. So we want them to be able to maintain. So using, if they do an embolectomy, which is where they go in and they actually take out the clot, they may attempt this before amputation depending on how long it's been since the occlusion, whether anticoagulation has started. We want to protect the limb from pressure and keep it at room temperature. A cold limb, the vessels vasoconstrict, so you want to keep the limb warm, and you don't want any pressure because we don't have a lot of blood flow, so we may get some skin breakdown. And then the best position is to keep the limb level or slightly dependent. So slightly dependent is down, okay? So slightly dependent. If surgery is not done within hours, that's when we need to make sure that anticoagulation therapy is started. They might consider using fibrinolytics or thrombolytics, but again, it depends on the patient and any other conditions they might have. So surgical management, we can go in and do revascularization. Revascularization is going to allow blood flow to be to areas that it wasn't before, which can cause the renal tubules to become plugged with myoglobin. And then we have lactic acid and debris that clogs up the small vessels and causes myocardial depression. And then edema can develop and cause compartment syndrome. So even though we go in and we actually fix it, we can actually have more damage from the revascularization itself. They can experience spasms and swelling of the skeletal muscles may occur. Compartment syndrome will be a concern. Again, monitor renal function and changes in the cardiac system. So I would expect that patient to be on a cardiac monitor. So Raynaud's syndrome is a somewhat of an autoimmune kind of condition, and So Raynaud's syndrome is listed. If you look on page 741, it talks about Raynaud's, it talks about Berger's, subclavian steal, and thoracic outlet syndromes. Those are all arterial health problems. In Raynaud's, we see vasoconstriction of the vessels. It usually comes from the patient's hands being really cold, nicotine, caffeine, or stress. It causes obstruction of the flow. It can cause painful vasospasms of the arteries and arterioles, especially in the digits. They get like a red, white, blue color change. It can be from some. So Raynaud's, I've seen it in patients with autoimmune disease like lupus. They have that bluish, reddish color to their palms. That is sometimes seen. Color changes in the hands. It causes spasms of the digital arteries, so the hands hurt. There's hypoxia, which causes the arteries to dilate slightly, so that's why you get that bluish color of the fingers. Manifestations, usually it's kind of a symptom kind of thing they look at, so they'll at least have it for 2 years. They'll have intermittent attacks of cyanosis. Sometimes it's a bilateral, sometimes it's just symmetrical involvement. There's no evidence of occlusion. So if they go in and check out those arteries, there's no real evidence that it's actually occluded. So treatment, keep the hands and feet warm and dry. Protect the body from cold because that makes it vasoconstrict. Sometimes we give them nifedipine, which is a calcium channel blocker. It helps decrease the frequency and duration because it helps with vasodilation of those vessels. It may only be necessary during the winter months because when their hands get cold, they get that severe vasoconstriction. And there is some stress management that they believe will help with this particular problem. They also talk about the patient should avoid grapefruit and grapefruit juice. Not sure. There's some kind of metabolite in that grapefruit juice that causes problems, and it causes problems in this particular disease. Then the other one, thromboangiitis obliterans or Berger's disease, it's also talked about on page 741 in your book. It causes claudication in the feet and the lower extremities. It's worse at night. It is related to smoking, and it happens more in men. These patients have an increased sensitivity to cold, and they may develop actually ulcerations on their digits. So it causes pain, digital ulceration, so they might have ulcerations on their fingers, and pain from the ischemia. It too causes color and temperature changes. Claudication pain is uncommon with pain in the arch of the foot. So they may have more pain in the arch of the foot versus any place else. Ulceration and gangrene are common. It appears spontaneously, and a lot of times it only appears on one extremity. Edema is common in advanced cases. They do see changes in the nails and skin, and that makes sense when you have decreased blood flow. They may have segmental thrombophlebitis, so the smaller veins may show thrombophlebitis in about 40%. And then the arteriography is the primary diagnostic. So we're actually going to go in and look at the arteries that feed the extremities to see if they're actually getting good blood flow. Again, many of the same teaching things: smoking cessation, pain management with exposure to cold. It talks about avoiding cold, wearing gloves and warm clothes, managing stress, teach the patient about nifedipine, tell them to avoid grapefruit and grapefruit juice, teach the patients about vasodilation and side effects such as facial flushing, hypotension, and headaches. So, and then we're going to talk about aneurysms. Aneurysms are formed when the vessel has too much pressure. There will be Abnormally dilated areas. So localized dilated or stretch area of the vessel. Most common locations are abdomen, chest, iliac, femoral, popliteal. Popliteal, assess for pulsating mass in the popliteal space. Femoral, there'd be a pulsating mass in the femoral artery. Do not palpate that mass because it might rupture. Assessment of patient's symptoms may be a limb ischemia, diminished or absent pulses, cool to cold skin, pain. Those are the kinds of things they're going to complain of. So the most common, you can see that I have several actually on the slide. Most common type of aneurysm is an abdominal aortic aneurysm. A lot of times they're asymptomatic. Discovery is usually on a like a x-ray that we're going to do before surgery, or we're doing a chest x-ray for some reason and we just happen to see it. There are several. There's the fusiform. You can see it's kind of all over and it's bulging. There's saccular, where it bulges on one side. Or you can have a pseudoaneurysm where you have like the walls of the vessel are pulling away and then the walls filling up with blood. So, aortic abdominal aneurysm, they may be aware that there's a pulsating mass in their abdomen. They may have back or abdominal pain. Groin or flank pain may happen because of the pressure on different structures. They may have a bruit that's heard in the abdomen, and they may have mottling of the extremities. The most common cause of an aortic abdominal aneurysm is atherosclerosis. It can be a late manifestation of syphilis. Taking antihypertensives are, patients taking antihypertensives are at risk of developing these, again, because they have hypertension. It may be located between the renal arteries and the aortic bifurcation. The bifurcation is where it goes into either leg. Pain is usually steady, gnawing quality, not affected by a movement, and lasts for hours or days. They may have a pulsation between the xiphoid process and the umbilicus. Usually at least 5 centimeters it has to be before it's detected. And like I said, you could auscultate for a bruit. These are an emergency. If these burst, there's not a lot we can do. You can't put pressure on it. There's a big problem. So we need to get them to surgery as soon as possible. Usually if we know there's one there, we do semi-annual monitoring if it's less than 4 centimeters. Lowering their blood pressure is key, so we want to make sure that we keep their blood pressure as low as possible. We might go in and do an aneurysmectomy, so actually go in and fix the aneurysm. Or we could do an endovascular stent graft. So you can see here, we put a stent in, and it supports the wall of the vessel and keeps the blood flowing. So that may be what we decide to do. Like I said, abdominal x-rays to confirm the diagnosis, and we also want to see if it's calcified. Surgical intervention will include resection or repair. An aneurysectomy, where we actually resect the aneurysm, has high mortality. So the endovascular stent grafts are a treatment of choice. Complications related to the stent placement is when they go in to fix it, they might have to actually open up and do a repair. There can be bleeding. There can be an aneurysm rupture. There can be peripheral embolization, so they actually get clots into the periphery, or there can be a misplacement of that stent graft. So, discharge instructions for someone who has an abdominal aortic aneurysm: no heavy lifting for 6 to 12 weeks. If they have stairs in their house, they may need to stay on the same floor, so they may need to use a bedside commode so that they don't have to go up and down stairs. No pushing, pulling, or straining. So when we say no straining, that means we don't want them to strain with bowel movements, so we'll make sure they're on a stool softener. No driving for several weeks. If it ruptures, it's catastrophic. It's a 50-50 chance of survival. Anyone over 50 with abdominal pain should be evaluated for this. So that's why when we talked about peritonitis, that's an emergency. This is one of the things they're going to check for if you come in with pain in the abdomen if you're over 50. It is an emergency situation. They're at risk for hypovolemia because of hemorrhage. So rupture manifestations, we get mental status changes, possibly paraplegia, hemiplegia, hematuria. We can even hear a murmur. Signs and symptoms, a pulsating sense in the abdomen, severe persistent pain that radiates to the groin, abdominal rigidity, which you know is peritonitis, anxiety, tachycardia, hypotension. They may also exhibit diaphoresis, oliguria, and loss of pulses distal to the rupture. And then there's one called an abdominal aortic dissection. It's not common, but it is life-threatening, and that's the one that I showed you on the first, that showed where the pulling away of the vessel walls. So the intima pulls away from the media, and they actually get blood that's going into, hemorrhaging into the layers of the vessel walls, which is very, very hard to control. You get deterioration of the aortic media, which is that center muscular layer of the vessel, is the most common cause. Hypertension is a contributing factor. Another contributing factor can be Marfan's disease. It occurs in middle-aged or older, and we see it more in men than women. Some of the things they complain of when they have a dissection is sharp, tearing, ripping pain, anterior chest, back, neck, throat, jaw, and teeth pain. They might have diaphoresis, nausea, vomiting. They might faint. They might feel apprehensive. They have hypertension, decreased or absent peripheral pulses, a musical murmur, altered level of consciousness, and again, they'll be at risk for a stroke or paraparesis. How are we going to know that it's a dissection? The test that we do is a transesophageal echocardiogram that can help us determine the size. And an x-ray will show that they actually have a widened mediastinal. And you can see that on this x-ray. Remember I told you dark areas show, that would be normal. But you can see that the middle is wider than it normally is. If you compared the other x-rays I've showed you, you'll notice that it's wider where that aorta should be. It's actually widening out. MRI or a CAT scan will be done if they're stable. Stent placement decreases the long postoperative recovery. Either that or they'll have to have an open abdominal surgery, which is, again, 50-50 chance, and there can be a lot of complications from that. Emergent management, we want to put in 2 large bore IVs. We're going to give them lots of normal saline to try to keep their blood pressure in a good area. Elimination of pain is our idea. We want to reduce that systolic blood pressure to 100 to 120, but we want to keep it, if they bleed out, we know that it's going to lower that blood pressure. So we want to maintain the normal saline. Morphine, we know it helps reduce the workload of the heart. Esmolol is to lower the heart rate and the blood pressure. And then we'll put in an indwelling catheter because we want to monitor their I&O very closely. Long-term management is systolic blood pressure maintained between 130 and 140. And usually they're going to go home. If we know they have one, they're going to go home on beta blockers and calcium channel blockers. Complications, if this does dissect, they can have cardiac tamponade, and remember that's where the blood actually dissects or goes into the pericardial sac, which causes the heart to not be able to pump effectively, so you'll have muffled heart sounds. You'll have a narrowing pulse pressure. You know what a pulse pressure is. That's systolic minus diastolic. So 120 over 80, the pulse pressure is 40. So a narrowed one would be, let's say, 120 over 90. So it's narrowing. It's getting closer. They might have pulsus paradoxus. That's where the beats are weaker during inspiration and louder on expiration. Patient will need surgery, which is a cardiopulmonary bypass surgery, and will be treated like an open heart. So that's what we would prepare them for. All right, that's the arterial side. Now we're going to look at venous. So peripheral venous disease, we're going to look at venous thromboembolisms, venous insufficiency, and varicose veins. For veins to function properly, they need to be patent and open with competent valves. Veins also need surrounding muscle beds to help pump blood back to the heart. So thrombophlebitis, that is an inflammation of vein with an associated clot. So you've heard me talk about before, if you have a vein or an artery and it becomes rough for some reason, you're actually going to have clot formation. Etiology and risk factors, superficial caused by IVs, or they could have a deep vein thrombosis, which is in the deep vein in the leg. Highest incidence is in patients who have hip surgery, total knee repair, or open prostate surgery. What have I told you about surgeries over and over and over and over again? All of the things that's going to keep them from getting thrombophlebitis is sequential hose, prophylactic heparin or Lovenox, early ambulation. All of those things are going to keep the blood flowing in those extremities. It's the healthcare's greatest challenge. Phlebitis is seen more with IV therapy. Other conditions that make them high risk is ulcerative colitis, heart failure, cancer, oral contraceptives, and immobility. None of those should be news to you. You've heard me say that before. Immobility such as bed rest for extensive illness or sitting prolonged periods like in an airplane excuse me, or at a computer will make you at high risk. So Virchow's triad is venous stasis, hypercoagulability, and injury to the venous wall. When you have two of those three conditions, then you have conditions present that a thrombi have formed. So hypercoagulability comes from cancer, thrombophilia, inflammatory diseases, vessel wall injury, surgery, chemical irritation, inflammation, and stasis of the blood, immobility we just talked about. So if you have two of those three things, then you're going to possibly have a DVT. So characteristics, we can look at a risk assessment. This will tell us how much high risk our patient's at, and it's all of those same things I just was talking about. So the higher score they have on this, the bigger risk they're going to be, and those are the patients that need prophylactic heparin or Lovenox, sequential hose, early ambulation, all of those kinds of things. Leg exercises if they can't ambulate. A score of 2 or more indicates a DVT is likely. DVT clinical manifestations: redness, warmth, tenderness. A DVT, usually you have unilateral swelling, pain, redness, warmth, and a low-grade fever possibly. Usually, we talk about Homensign in basic or fundamental nursing, but Homensign has been found to not necessarily be reliable, so we don't use it as much anymore. The biggest thing we do is if they have redness, warmth, or tenderness in one calf, and we look at the other calf and compare it, and there's a definite difference, then they probably have a DVT. What are we going to do? We're going to do a couple of tests. A D-dimer is a global marker for coagulation activation, and it measures fibrin degradation products produced during fibrinolysis. So that is one of the things we do first that tell us if there's actually formation of clots in the body. After that, we're going to do a venous duplex, non-invasive ultrasound, and assess the blood flow through the veins of the arms and the legs. And then we'll do Doppler studies that may be used to be more specific to the proximal versus the distal veins. What are we going to do for management? Medical management is going to be anticoagulation therapy. It stops new clots from forming. It does not break up clots. It stops new clots from forming. Things like heparin, low molecular weight heparin is Lovenox, or Coumadin. Those three things. Anticoagulants are the drug of choice for an actual DVT, or if the patients are at risk for a DVT. Heparin needs continuous monitoring due to unpredictable patient responses. It prevents other clots and an increased size of current clot. Before giving a baseline, prothrombin time needs to be done, an activated PTT needs to be done, an INR, a complete blood count and a platelet count, a urinalysis and stool for occult blood, and a creatinine level. So there's a lot of blood work that needs to be done before we start somebody on a heparin drip. If the patient's platelet count is below 100 to 120, depending on what your agency policy is, you need to get a hold of the physician. Usually we give a bolus of 80 to 100 units per kilogram of body weight, and then the rate is based on the PTT. Therapeutic is 1.5 to 2 times the normal. So you want to look at the normal PTT, and then it'd be 1.5 to 2 times that. Usually at least a daily PTT is drawn, and anytime you make a rate change, 6 hours later another PTT should be drawn to see if it's okay. And as you all know, the antidote to heparin is protamine sulfate. A decreased platelets may be seen with Lovenox. The body makes antiplatelet bodies within 6 to 14 days after beginning treatment. They may need to discontinue if the platelet count is too low. So if you give heparin, you want to monitor your platelets too, because they can get what they call HIT, and that's heparin-induced thrombocytopenia, and that's where your platelet count actually drops lower. But you also want to monitor your platelet count when you're given Lovenox. Lovenox is good because we can actually use it for patients at home. They can give themselves shots at home. We know that we need to start them either on heparin or low molecular weight heparin like Lovenox, and get that PTT up to where it needs to be, and then start Coumadin, because it takes 3 days for the Coumadin to get to where it needs to be for the PT and INR. So you want to make sure that you're actually starting that Coumadin before the heparin's actually turned off. And then we titrate that. And as you know, the antidote to Coumadin is vitamin K. So patient teaching needs to be done for patients who are taking Coumadin, because vitamin K is found in a lot of fruits and vegetables, and we need to make sure that the patient is aware of that. If that doesn't work, if that doesn't stop the growth of the clot, we may have to go in and remove the clot. It's very rare that we do that, but we could have to do that. If we're doing surgical management for DVTs, a lot of times what we'll put in is an inferior vena cava filtration. And that is placed into the inferior vena cava, and it looks like a little umbrella. And what it does is it catches clots in the inferior vena cava, and the body will naturally absorb those and break those down. Post-op, we're going to inspect the groin, because it's usually done during a cardiac cath almost procedure. We'll inspect the site for bleeding and signs and symptoms of infection. So nursing management, these are all the things I've been telling you for a long time. Promote blood return. Elevate legs if they're up in the chair. Use TED hose or sequential hose. Warm packs. Now, warm packs on a DVT leg, that needs to be a specific order by a doctor, because we know warm packs vasodilate, so it could actually cause movement of the clot. But your book talks about warm packs. Just make sure that those are specifically ordered by the doctor. Maybe a mild analgesic. We're going to monitor their anticoagulant therapy, so we're going to look at PT, PTTs, INRs. We're going to monitor for bleeding, so we're going to look at their gums. We're going to look at their urine, their stool, if they have any wounds, if those are bleeding. We're going to monitor for a PE, that's a pulmonary embolism. They will experience tachycardia, dyspnea, crackles, anxiety, diaphoresis, and wheezing. Supportive therapy. They're usually on bed rest with elevation. Studies have shown ambulation did not cause pulmonary embolism and DVT did not worsen more. Allowing patients to ambulate actually decrease fear and anxiety about dislodgement. Always check with the provider. If the patient is up to the chair, elevate their legs. Do not massage where that clot is. Prevention, reverse the risk factors. Passive or active motion, we've talked about. SCDs, elevate the foot of the bed, compression stockings, passive range of motion. Post-op deep breathing promotes the thoracic pull of as a negative pressure, so it causes the venous to work better. So even deep breathing exercises are good. Pharmacological measures, Coumadin, heparin, and Levinox. They should avoid smoking. They should avoid birth control. They should avoid contact sports. They should have a medical alert. They should tell patients to let any caregiver know that they're on an anticoagulant. So a dentist, chiropractor, anybody that's going to give them any of those kinds of things, they need to tell them that they're on an anticoagulant. Prevention, avoid standing or sitting for long periods. No pillows under their knees post-op. That causes dependency of the feet, which is going to cause potential for clot formation. Pressure on calf muscles, veins during long surgeries. Prevent that from happening. Avoid infiltration of the IVs. Contraceptives. I can't say it enough. Contraceptives can make a patient more likely to have blood clots. Chronic venous insufficiency. I think you've probably seen some legs that look like that. That comes from dysfunctional valves that cause venous stasis. So it causes backflow of blood because of the inability to push the blood back to the heart like it's supposed to. The valves are destroyed. So therefore the blood flow is bidirectional. It goes up and it goes down. Capillary thrombosis is the end result, so it can actually cause the capillaries to develop little clots in them. Eventually, there will be ulcerations. They will have swollen legs because they don't have the ability to return that blood flow as well as they should. They get a brownish color to their skin. Their ankles, they have what they call stasis dermatitis. And then ulcerations, and they have itchy, scaly skin. Occurs at the end of insufficiency, usually the lower third of the leg. Ulcerations are usually at the malleolus and the inner ankle. They have irregular borders, so they're not those nice round ones we saw in the venous or in the arterial slide. And chronic, a lot of times they have chronic ulcers that are difficult to treat. If they do have those problems, we want to elevate the legs. You want them to elevate them as much as possible, 8 hours a day. No crossing of the legs. Feet should touch the floor. No garters or rolled stockings. We will do wound care, will be moist dressings with compression. So a lot of times they do kind of a wet to dry with compression. Walking's encouraged because that's going to increase the muscles to help move that blood back and forth and not create clots. Cultures for infection should be taken. Usually we cover with non-adherent dressing like Telfa or Adaptive. Stockings can't be worn if the dressing is on because it won't fit. So a lot of times we're unable to put stockings on these patients. And then they might have what we call an Una boot. It's a bandage that has glycerin, zinc, and calamine, and it's placed directly over the wound, and it stays on for several days, like a week, I think it stays on. Skin grafting is really rare because if they don't have good backflow of blood, it's not going to necessarily heal real well. Collaborate with the wound care nurse. Focus on treatment is to decrease edema and promote venous return. Ask the dietitian to increase the zinc, their vitamin A and vitamin C, as well as protein in their diet. Graduated compression socks from the middle of the foot to just below the knee or thigh. They need to wear those day and evening, and they should not roll them down. If they don't fit properly, they need to get new ones. Avoid prolonged sitting or standing. Do not cross your legs. Do not wear tight, restrictive pants, girdles, or garters. So what we see, okay, so I want to go. That other slide talked about elevating the legs for 8 hours. No crossing the legs. Feet should touch the floor. No garters or and that's how we treat chronic venous insufficiency. These are varicose veins, permanently distended veins with loss of valvular competence. So the valves in the veins that are supposed to help move the blood flow back toward the heart are incompetent. So they get larger because they're unable to move that blood. They actually distend. It can be primary or secondary. Primary is usually a congenital problem. Secondary is from trauma, obstruction, inflammation, or DVTs. Their symptoms are aching, itching, swelling, unsightly appearance. They have a feeling of fullness. They have what they call telangiectasias, which are spider veins. Generally, patients think they look bad, but they're not any more serious. They just are more superficial, and that's why they look more spidery. Diagnosis is generally made by an ultrasound of the vessels. Conservative measures are elastic compression hose, exercise, and elevation. Our goal is to improve comfort, and we can do that possibly with compression stockings. To treat that, there are ways to treat it. We can do what we call sclerotherapy and ligation. Sclerotherapy is where we use like a 25% normal saline solution. You know, normal saline is 0.9%, so a 25%. What it does is scar the vessels, and they actually shrink after we scar them. Or we can do a ligation. We don't do ligation and strippings very often, but we can do those. The scleropathy, we inject the agent, it damages the vein. The pressure on the leg causes the walls to grow together, so that's more cosmetic. If we do a ligation, they have an extreme problem usually. That's where we tie them off. Elastic bandages are worn after exercise, and then there's elevation of the legs for short periods. Elastic bandage is worn after for 1 to 3 weeks, morning to night, when we do scleropathy or a ligation. Varicose vein management. We can also do endovenous laser treatment using laser heat. And we can do radio frequency ablation using, again, it's a kind of like an ultrasound heating element. It may need to continue for 3 therapy for years. Assess the limb for vascular status, color, temperature, pain, edema, paresthesias, and possible nerve. Post-procedure, they'll have compression bandages for 24 hours a day, except when they shower. They'll get a follow-up ultrasound, and they'll be monitored carefully for the first 6 to 8 weeks. But you can see in the picture it does make a difference. Lymphedema is the accumulation of lymph fluid in the interstitial tissue. It causes swelling in the arms and the legs. It eventually causes reduced oxygen and interferes with wound healing, and it leads to infection. Primary can be a congenital problem, bilateral mild edema of the ankles and legs at puberty with maybe some congenital blisters filled with lymph form on the skin. That's a primary lymphedema. Secondary is due to damage or obstruction. So when I think of lymphedema, I think of after breast cancer, they possibly will get lymphedema in their arm where they had the mastectomy, and that's because we went in and manipulated the lymph system in that area. So that's one reason, if they had any trauma or if they had radiation at high levels. Now, when I also think of lymphedema, I think of what you see as elephantitis, and that's where the legs are abnormally huge in some obese patients. There's actually a little worm that causes that, and it gets in the lymph node. It's called philoniasis. It comes from mosquitoes. I talk about that because sometimes you do see that. You can see in these pictures, primary, like I said, is congenital. You'll have that bilateral edema. Secondary is due to damage. Probably you can see this arm. The lady's had a mastectomy. Secondary can be trauma or radiation at high levels, and you can see in that the difference in the legs. Those are lymphedema. And then the only pediatric thing that we're going to talk about that it talks about in your HESI book is something called Kawasaki's disease, and it's a mucocutaneous lymph node syndrome. So if we were going to talk about a congenital problem, this would probably be one of those. It's an acute systemic vasculitis. They have damage to the vessels, including the coronary arteries. So they get permanent damage to the main arteries of the heart, and they may even form an aneurysm of the coronary artery. Cause is really unknown. Ages 5 and under, it's the leading cause of acquired heart disease. So we talked about congenital heart disease, but in this particular disease, in Kawasaki's, they actually acquire it due to this particular problem. Early treatment is essential to prevent damage. You can see some of the diagnostic features in that picture. They have red, dry, cracked lips and an inflamed tongue, swollen lymph nodes. They have a widespread rash, red eyes, changes in the hands, the feet, swelling, redness, and then that peeling of the skin around the fingernails and toenails. Whenever I see peeling around the skin of the fingernails and toenails, that's definitely a big problem. There's definitely something going on. There's 3 phases: acute, subacute, and convalescent. In acute, they have a high fever for more than 5 days. They get that conjunctival redness that we talked about, that strawberry tongue, red swollen hands and feet. Subacute is when they start that peeling that occurs at the fingernails and toenails. And then convalescent is when the signs have completely gone and their labs are starting to return to normal. During this whole process, the child is going to be extremely irritable. So the extreme irritability is in all phases. How do we treat it? We give them an IV immunoglobulin. Immunoglobulins are given for patients who have don't have the immune system. You have like IgG, IgE. Those immune globulins help boost an immune system. So we give immune globulins. We treat the high fever with acetaminophen. And it talks about aspirin in your book, but we all know that aspirin shouldn't be given in children under the age of 13 because of Reye syndrome. But it does talk about that. And then we monitor their cardiac status. So if I had a patient coming in with Kawasaki's disease, I think coronary heart, I think monitor the cardiac. Okay? So monitor the cardiac status, look at intake and output, daily weights, minimize skin discomfort with lotions and cool compresses. Initiate meticulous mouth care. monitor their intake of clear liquids and soft foods, support the family because the child is extremely irritable, and then provide discharge teaching and home referral for these particular patients.